Good evening, everyone. My name is Josette Dubois. I am the Adult Programs Librarian for Slover Library, and welcome to our evening session of Dementia, the Continuum of Care. Please use the chat feature if you have any questions throughout the presentation, and we will give you some opportunity at the end to ask some questions as well. And so I'm going to go ahead and turn everything over to Ms. Joan Motley. Take it away, Joan.
Thank you very much. Good evening, everyone that's joined us tonight. Thank you very much for coming on a line with us during this beautiful weather that we seem to be having this evening. I am known as the Business Development Representative and Family Liaison for Interim HealthCare, based in Virginia Beach, and we cover throughout the Hampton Roads area for care and support in families' houses, or wherever they might be residing. I have an extensive background in Alzheimer's disease and related dementias, and I've actually created this particular program. This is one of 16 educational programs that I've actually designed and developed at this point. And I developed this one in particular for what do we have on our plate, using that kind of terminology, because I've often found it very disturbing that many times families do not quite understand, what it is that they actually have on their plate, understanding that diagnoses and understanding how to plan forward. So truly grasping onto what is this continuum of care, this big picture that we really need to understand before us. If we're not quite getting it, we're not going to be able to sustain our loved one in their home setting for as long as perhaps we had originally wanted. All right, so let's go on to the first screen. Thank you. And for the attendees, please know that I'm going to be talking a bit fast because we're going to try to crunch a lot of things down into this this program. Please realize though that if anybody wants to continue to send me a message or reach out about where else I'm doing this program, as well as the other ones, I'd be more than happy to let you know, because I am going to be crunching things down a lot faster in a process than I normally would have if I was in person. So the impact of Alzheimer's disease and dementia. So first off, we do at the moment have, that we're aware of, over 50 million people worldwide with this type of decline and 5.8 million in the United States. The 5.8 million, though, are only the ones that we're truly aware of. I say that to you because there are tons of people out there that are not informed about the importance of going to a neurologist and establishing a baseline to understand exactly what this diagnosis is. So if perhaps we are someone that has just stopped at the doors of a general physician and have not continued to understand a diagnosis besides the fact that we heard the word dementia given to us, and they are part of that very large percentile of people that we are unaware of. Projections are going to be climbing quite terribly on us by the year 2050. We are going to see over 14 million people. And we do need to take note as to what this is doing, this role of being a caregiver is doing for those that are in that type of position. If we do not have somebody, a caregiver, that is actually getting enough support from extended family members, as well as the right type of support and services inside a home, you'll greatly see a decline even in that primary caregiver. Their own health and well-being many times becomes in jeopardy. They certainly are beginning to put their own needs to the side because we tend to focus on what our loved one is requiring of us, and it certainly becomes a big burnout position. And I'm sure anybody that's out there that's in this role, I'm kind of preaching to the choir, but it is something that we need to take note of and realize that if we don't have that right type of support happening, again, it's going to be very challenging to sustain somebody in this house. So a good 80% of those that are providing this care is being done by those primary family members, as well as perhaps reaching out to those family and friends that we might try to rely on. And of course, this becomes very challenging. Again, another kind of wrench in the system of trying to sustain somebody successfully for the long run for that continuum of care in that home. Okay, next screen. Okay, so let's understand this aging process, this difference between normal aging and what are we beginning to see somebody that might start to identify a more of a concern. Picking up on the fact, and we have to become knowledgeable of the fact that when we start talking about these dementias, each one progresses in a different fashion. Okay, so it's important that we understand which disease is it, because if it's somebody that might be now beginning, show us the beginning stages of Alzheimer's disease, we are going to see more of that repetitiveness in somebody, more of that confusion of day-to-day tasks, losing track of where things are. But perhaps we have somebody that's showing a lot of inability in making appropriate decisions. We're seeing maybe a lot of outbursts. Maybe we're seeing somebody that has a lot of behavioral issues and making very poor irrationale. Maybe we're seeing a different type of dementia in that particular situation. So the risk factors that contribute to somebody's potential of coming down with dementia happens to be if we have a connection with diabetes, if we have a connection with hypertension, a high blood pressure, if we have a connection with somebody that is, if we are somebody that has been smoking for many, many years in a row, perhaps also somebody that has been a very big drinker for many, lasting years. If we also have somebody that has been living in isolation, that is reluctant to come out and socialize and be part of all those fun and frolics that we should all be doing for ourselves. Individuals that are not participating in activities and are more prone to keeping to themselves are actually at a very high risk. As well as even those that are in a less fortunate situation than ourselves. In that case, I mean, people that might be homeless as well are also at a very high risk. Determining a diagnosis is very, very important. Many times I hear people say to me, why do we need to understand a diagnosis? And I could go on and on and on about why we need to have a diagnosis and why it would be important, and not just to continue to think it's just dementia and stopping right there. Without us really understanding what this diagnosis is, what this actually is on our plate, it'd be very challenging for anyone to understand how this particular decline is going to move and groove and progress as another 3 months, 6 months, 1 year continues. So if you don't understand which disease it is, you will not have a very clear understanding as to how it is going to progress in a matter of time. Also, what kind of medications to have thought about, and how is this going to hit our pocket for the long run in sustaining this individual either in the home again, or even considering outside, the home assisted livings and the cost factor and something like that. And most importantly, by the way, is how is this connected to us hereditary wise? So when we want to determine a diagnosis, many times you might just go to the primary care physician and begin to hear the word dementia now being given to you after a small mini mental assessment might have been provided. It is important that we realize that if it had not been said to us to go on to a neurologist, that we should be pursuing that direction. You need to establish a baseline at a neurologist level, be able to do the right scanning, blood work to determine exactly what this is. And with these scans, we're able to determine with a very high accuracy what this is beginning to look like. So where is the shrinking on the brain? Where are we seeing the decline on the brain? Where are we seeing perhaps the reduction in white matter? So we need to keep track of this, and initially it should be every 6 months to once a year. As things progress, we should be actually increasing our own pace going, and for our follow-up visits, which is every 6 months. So many times people might initially say, oh, it's just old age. Oh, this is just very typical of this person. So we need to really keep track of what becomes the not so normal stuff. Okay, in an individual. And if for that matter, I would say get out a little marble notebook and start to document what are we seeing in this person on a day-to-day basis? What is so different from today, from last week, from last month? What are we doing for this person today that we've never had to do for them before? Start keeping track, as well as how their behavior is changing, irritability and so forth. When you do the neurologist trip and you're going on over in that direction, it is also important that you have somebody that's going to be very responsible and very vocal with this person by by the side of the individual that is declining. Many times the person that might have this type of decline is going to have difficulty recognizing it, or perhaps even admitting to the decline is even happening. I have my pride. Oh, no, I'm fine. It's all the rest of you that has a problem. So, we need to really make sure that we have another individual that is going to be able to express to a neurologist exactly what we're seeing in this person, and again, what is so different. Many times you might have a well spouse that is beginning to cover up for an ill spouse because they're reluctant to, to really acknowledge and admit to the decline, because this is a very big blow if we have to admit it. And that's a whole other part of a conversation. But now I want to go on, because I want to keep up my pace here on, keeping in mind advancce directives. We need to make sure that all of our advancce directives are done way before we even know of a diagnosis. And the advancce directives is an umbrella term that we're going to be using to identify our wills, living wills, power of attorney, healthcare proxies. Very important detail that goes into all those documents. If anyone needed to have any direction with an elder lawyer, I'd be more than happy to guide you in those directions. But it is also important that we realize that if somebody is beginning to exhibit a decline, that we have these advanced directives done in a timely fashion. If now we've gotten to a point where this person is having great difficulty deciding, making any decisions, and having difficulty following directions, then we're going to start to kind of cross a line of where they might no longer have that capacity, the true capacity to be able to understand a document and be legally allowed to sign off on it. Those individuals that do not have these advanced directives done in a timely fashion are also the ones that are up the creek, and they most likely will have to go on for guardianships, which is thousands of dollars. Which is a whole nother conversation. It's important that we also think about Medicaid planning and realizing that there is a chronic Medicaid that is used for skilled nursing home placement, which is a 5-year look back, which means that we have to find 5 years of documentation, proof of all our income, assets, everything that's been connected to this person for the past 5 years, and protect it properly. And that again will involve an elder lawyer to protect those assets. We do have various types of trusts out there that are range in pros and cons. And so it's important that a family realize perhaps what is best for you, especially if we're trying to plan on keeping this person in their home. So I have some feedback to even share on that if somebody wanted more, information about that, and understanding how we get somebody approved for home-based Medicaid, because if you were to do that, you can actually get up to 40 hours a week of care in the home. Okay, move on, please. So when we begin to see that there is a memory issue, we might initially begin to hear from a physician, or most likely, hopefully, knock on wood, you've gone your merry old way to a neurologist, because that is where maybe we're going to start to hear that word MCI. MCI is known as the mild cognitive impairment. It's important that we recognize that the MCI word, though, is the precursor to dementia. So initially, when somebody is diagnosed, yep, we know that person's showing a decline. We know that there's some confusion and some repetitiveness. And oh, yeah, we're getting real involved and giving them tons of reminders about things, which is maybe becoming a tad bit annoying. Right. But when somebody is diagnosed with MCI, watch that we're going to begin to see that perhaps a year, 2 years later, if not quicker, that we're going to start to see more and more of this memory issue. If we had followed up with the neurologist and we began to do the scans on the brain again, perhaps we're seeing more definitive shrinking that's going on, again, on one part of the brain versus another. If we do start to see that there is an assessment that's being done where now you're asking me a lot of direct questions, but I'm showing you more and more anxiety, and I'm a little annoyed that you're putting me on the spot. And so I start to give you a little roundabout answer to questions, making you think that I've answered, the question, but I truly have not. So they start to give a whole roundabout response to things, becoming very vague. So we start to realize that the memory issue is more defined as just dementia for now, and dementia is the umbrella term. So when we have that umbrella term, it actually means that the individual has a cognitive decline in their ability to understand and process information and retain information. And so that is going to be it's only going to be dementia for so long. We're dealing with a progressive decline. When we start to hear the word dementia, we have to realize that there is going to be a progressive link as time goes on. And we'll be able to see as we move along, what is this really beginning to look like now? But when somebody does have a dementia terminology now attached to them from this diagnosis, dementia is never a normal stage of decline, and it's never a normal stage of our aging process. So it is a misconception for anyone that thought otherwise. Alrighty. Okay. So underneath that umbrella, we start to identify some of those key diseases, such as Alzheimer's disease. We kick off with that one because it is the largest form of dementia. It is the most commonly diagnosed. And there is what's known as early onset and late onset. If we came across an early onset situation, now we're going to have somebody fairly young. We could have somebody, believe it or not, as young as 35 years of age. The range typically goes to about a 65-year-old. If you have somebody in this type of a range, you're going to have somebody that perhaps still has a career and normally would have been working, but most likely they're having difficulty keeping up with their responsibilities, in which case they might be let go and laid off. Early retirement deals are being made, and now they'll have to head on home. Somebody else has to now pick up the slack and become that primary financial supporter in that house, as well as now becoming that individual's caregiver. So that becomes a huge blow in a family, but it is a very young individual. And the pace of the disease for early onset goes very quickly. All the stages of the disease kind of get crunched up together, and it goes very fast on somebody. Typically, I've seen about an 8-year span from the time of diagnosis to the time of someone passing. It could be as many as a good 10, 12 years at times, but there's a lot that goes into play of why perhaps somebody might be declining sooner than somebody else. And that's a whole other part of a conversation that I don't know if I'm going to have enough time today to do that. But late onset now is you're going to have somebody more so into the 70s and 80s. We see a lot more of that type of a scenario surrounding us. And now the pace of the disease will just go a wee bit slower. So it's not as quick paced as the early onset situation. By the way, with early onset, it is an extremely hereditary link in a family, and it does make up 5% of our entire population. When we look at late onset, now it becomes more of a 50-50 risk that we might have some concerns of it being linked to family. The biggest contributor of late onset actually does happen to be age. So as we all are inching closer to our 80s, we are more at risk of developing something like this. Vascular dementia would have been brought on or as a contributor from a stroke, multiple strokes, or a heart attack. If we also start to see that not only is there a memory decline after that type of an experience, but also behavioral issues, we might now begin to see some of the characteristics again of Alzheimer's disease, in which case we could have somebody that has a mixed dementia, which is also very common. Vascular dementia was the initial culprit, and then we might also begin to see the signs of Alzheimer's disease. Lewy body dementia is that third most common, and Lewy body dementia is connected with Parkinson's. It's wise for us to realize that anyone that has Parkinson's disease, we do see a good 60 to 80% of those that have Parkinson's eventually do develop a form of dementia. And in particular with Lewy body dementia, we started hearing more about it after Robin Williams had taken his life. He actually had that type of disease that not many were aware of. And Lewy body dementia is going to be primarily marked off. Some of the big characteristics happens to be hallucinations and delusions. We will also see some, fall risks, perhaps tremors. But when you think of Parkinson's disease and you have two people side by side that have Parkinson's disease, it would be very common that you'd actually see that they do not actually have all the same symptoms. So somebody might have more of the shakes and trembles versus somebody that really won't have all that, but might have more of the memory issue now developing. So now I want to move on to frontal lobe dementia for a moment. Frontal lobe dementia can be very tricky to diagnose. We do see more women than men, more women actually in the 50s and 60s. We also see that it also can be very difficult to diagnose because this person will have already been exhibiting a great deal of inappropriateness to us with language, behavior, or irrationale in their thoughts and decisions. But maybe they were always somebody that never made the best decisions in life. So we might have a really hard time figuring out what is so different. But if we had gone to that neurologist, in this case, you would have seen terrible shrinking occurring on the front temporal lobe. And any kind of damage that's ever done on our front temporal lobe part of our brain would greatly impact our emotions and decision-making skills. I'm going to move on to alcohol-induced dementia, and that would have been brought on, again, if somebody had been a very big drinker during a number of years. We will see a memory issue as time goes on. We do see links for people that have alcohol-induced dementia, links to people that perhaps have been in a first responder role in life, that have dealt with a great deal of stress and perhaps have seen some pretty horrendous things in their day. But there have been a great deal of diagnoses and links to those in first responder roles previous in life. Okay, we're gonna go on. Medications, pros and cons. It's important that we realize that when the disease is progressing, there is so many challenges that develop when somebody is exhibiting a lot of anger and frustration and resentment about you now becoming involved in their life. And, oh, no, don't you touch my things. This is my stuff. Oh, no, don't come in my house. Don't, what are you doing? And so when we start to see more and more behavioral issues and defiancy about even taking medications or even following through with going to the doctor, nope, I want to stay in my house, leave me alone. We might really begin to have some challenges, not only doing those follow-up visits, but also making sure that we always have the right medications in check. When we think of the dementia medication, I do want to say to you that sometimes, I'm not, it's important that we have the right meds in place, but it's very, very important that we realize that we can't put so much just in that bucket, relying on the meds, because the disease will continue to kind of run havoc and take its course on us. And a lot of things that we need to really consider, though, is what are the dynamics in that house where this person is residing? How much stimuli do they have? Am I sitting down just watching TV all day? What kind of activities are you doing with me? So the busier this person is, the more active we are able to keep this person, the less agitation we will see. Because if we're able to get them focused on something and actively involved in something, we'll see them less fixated on a thing. And if we're not giving them that ongoing guidance and support, we're going to need to really get very creative, even with these medications, to be able to keep things at a calm level. Aricept is one of those beginning medications that we might hear about. Aricept is most appropriate, or maybe even donepezil we might hear about, or Exelon patch, Exelon oral pill. These are the kind of medications that typically are given in the very beginning stages of the disease. Once somebody really is no longer in the beginning stages, and now we're kind of hitting the middle of the road, that's where you're going to start to hear another medication kind of be brought to the table, and that's going to be called perhaps Namenda. Namenda and Aricept come together, they form a cocktail, and we start to bring these medications jointly together now in a combination drug that goes perhaps until about almost the very end of the disease. At which point we'll get to a point in saying, as things are progressing, gosh, what the heck is it even doing? What benefit do I even see in these medications? And eventually we will be tweaking and removing these medications right back off again. What the medications are doing is that they're helping the individual with their comprehension, their understanding and processing of information. So if I'm on the right meds, if I'm taking them consistently, if I have somebody monitoring me taking them, I'm not feeding it to the dog or hiding it underneath my napkin, and I'm not skipping a beat, because you have to build this medication up in the body, and it takes a good 2-3 weeks just to see if there's any kind of a difference. but it does clear away that passage of great misunderstanding and confusion. So if I can kind of grasp what it is that you're trying to say to me now, and I'm getting the right guidance and support, you will see that this person will be less agitated, less argumentative as a result. If we don't have the right meds, if we're not successful in going to the doctors for these checkups and getting the right combinations in place, it wouldn't surprise me if we had to now go to a hospital setting for stabilization. If we were trying to go to a hospital to become stabilized after maybe 3 or 4 days there, the hospital might say, oh, well, there's not too much more we can do. Perhaps now we might begin to hear that they're going to send us over in the direction of a psychiatric hospital. Very, very common, very typical, in order to continue to stabilize somebody. That is a short-term stay situation. That is not a long-term stay. You should be aware of the clinical trials, which typically are not spoken about very often, unfortunately. It's up to the family to continue to be that voice, continue to be that advocate for a loved one, and speak to the physicians and the neurologists about what are these clinical trials that might be in local hospitals around us, and the scientists that are at work trying to help us get to the cure, and even stopping these diseases in their tracks. If we were part of a clinical trial, though, and even though I had the placebo and you had the real thing, and now it was proved to be effective, and now it could go onto the market for another medication we can all use, then anyone that was part of that clinical trial can all take advantage of that same medication, as well as having what's known as the PET scan for free. The PET scan is one of the most accurate ways that we can determine even Alzheimer's disease. And that is a very expensive test, usually over $10,000 plus. Many times it is not covered by insurance, but when somebody is appropriate for a clinical trial, I'm the right age, I'm the right disease, I'm the right stage of the disease, then I can be part of this trial, and you can get that test for free. Okay, move on, please. So when we're trying to strategize and we need to sustain somebody in a house, we have to really think about how are we going to modify this thing? What begins to be the concern here? Because, is this person, are they showing us that they are calling us the minute that we've left their house? I mean, we spent all day there, helping them out with this and that. And now they're calling us again, where are you? You haven't been here all day. Meanwhile, we were already over there, So how repetitive is our loved one? And what are they still able to do for themselves? What are we now becoming involved in? How are they more and more reliant on us, to the point that perhaps there begins to be some red flags that we should be picking up on that are showing us some safety concerns? Are they leaving food out on the counter? Are they not wrapping things up properly? Are they just putting things on the shelf in the refrigerator and not wrapping properly? Are we opening up the refrigerator, even seeing things that perhaps are no longer safe to even eat? Are they, is it stale? What kind of hygiene concerns are we beginning to see? Because they do become very reluctant about going into that bathroom, that room where now I become very overwhelmed. Oh gosh, what do I have to do in there? They have to remember how am I even, washing myself? All these various steps. It becomes another big conversation that I can tap into. But we really have to see, what is the condition of this person? Are we smelling an odor? Keep in mind that we might say, oh, what was the last time you took a shower, Mom? And Mom would be like, oh, well, look, I'm all set for the day. I'm done. Well, meanwhile, in her mind, again, she's pulling from her long-term memory bank now. I know back here, I took a shower at one point in time, but here and now is I'm not quite understanding, or I'm not quite able to retain even new information to know for sure, did I take a shower or not? So we do begin to see that the retention to hold information in the short term here and now becomes very challenging, and that time frame of what they can retain continues to shrink down, which is, again, another part of a conversation actually that I'm tapping into in about 2 weeks from now. So with safety concerns, are they beginning to wander? Even though I've never wandered out that front door on you before, doesn't mean I'm not going to do it. So don't assume that the person is not going to do it tomorrow, or 1 month from now. So do we need to think about an extra latch on top of the door? Because if now I'm inside the facilities and taking a shower or what have you, that person could be right outside that door in a heartbeat on you. We have to realize, what kind of fire risks are going on. Are they still smokers? Are they leaving, the cigarette butts out? Are they putting it out correctly? Are they leaving ashes around that could begin to smolder and now become a fire risk? So watching out for those cords, all the fall risks, the rugs that could be slipping out from underneath them. Are we dealing with the stairs? That the bedroom is upstairs, but gosh, they're showing us some balance issues already. How safe is it to continue to climb up those stairs? We only have one bathroom in the house. Is it upstairs, or can we maybe modify something and relocate them downstairs? And even as we're trying to ask them to complete a task, minimizing distractions would be very wise. And you need to speak a lot slower than I am now. You need to speak very slow and give them a chance to respond. If you are rushing them and you're also anxious and irritated that, oh God, I already told you this, Mom, why am I saying it again? They're going to certainly detect your frustration and anger, and you're going to get their anxiety level and anger at a certain height where it could take all day long to finally calm them back down again, and perhaps you pretty much have ruined the whole rest of the day because that anxiety is very difficult to redirect them unless we have another activity up our sleeve to get them going. So creating a daily plan for activities and structure would be very wise. So again, as I touched on a few minutes ago, the busier we're able to keep them, the better off we are. If you have somebody that has too much free time on their hands and they are not even going out, there's no activity anymore besides, getting up and now sitting in that couch and watching TV, this will add to their decline. It's going to progress their decline. When you think about, they're watching TV, well, as the disease progresses, they're going to have great difficulty even understanding what they're watching, following the dialogue, following the plot, what's going on. They're going to watch the same thing over and over again as a result, and not being able to retain what is even happening. And even if they were looking at a newspaper magazine and they're just staring at something, if you're curious about how much are they really understanding in that article, to say, hey, Mom, I didn't get a chance to read that yet. That looks really interesting. What is that all about? Watch how the individual with the decline will perhaps be very frustrated and say, here, you read it. You do it. They immediately try to put it back onto your side because they don't want to answer the question. Oh, somebody have a question.
I don't see anything, but Scott, if you do have a question, go ahead and put it in the chat box.
Scott asked, can you send links to home care or daycare options for seniors? We are both working full time and my mother lives in our house with us. Okay. Yes, I can give you some information on daycare. I mean, for instance, if you're in Virginia Beach, a location I would say to you would be the M.E. Cox Adult Senior Center. It's here in Virginia Beach, not far off of Virginia Beach Boulevard. I think it might be roughly $50 a day. Of course, right now with what's going on out there, things are very limited to any of these group settings. So, but that is something that is local. As far as options for care, I guess I should probably, since we only have another 5 minutes or so, let me explain to you who I am. Can you go forward to I think it's the second to last screen, actually. Yep, there we go. All right. So Scott and whoever else might be on this call, I again represent Interim HealthCare, home care and hospice, and Interim Home Care actually happens to be the oldest home franchise agency in the United States. So we were the very first ones that ever kicked off home care back in 1966, believe it or not. Our headquarters is down in Florida. The office that I actually work from is here in Virginia Beach, right by Mount Trashmore area, if you're familiar with that neck of the woods. And I am the individual that normally would help families coordinate that companion care or personal care in a home. So when you think about what do families need, and with Interim, we actually it's basically one-stop shopping for a family. Anything that you could require as time goes on for that continuum of care is underneath this one umbrella. So companion care typically is that piece that would be very wise to introduce somebody to as early in stages of a decline as possible. The sooner you get somebody accustomed to care in a home, coming from someone other than you, other than family members, is huge. Okay, huge. All right. So we want to make sure that they are slowly building a momentum of getting somebody, getting accustomed to somebody. I can, if you wanted to reach out to me, I could tell you that we're extremely flexible with days and hours and all that great stuff. Personal care now becomes more hands-on assistance. So if anybody needed any hands-on contact for showering, dressing, grooming, that's the personal care piece. Skilled care is what is given underneath a doctor's authorization. If we were discharged from a hospital or a rehab, or we needed to have PT/OT in a home, or home health, as I would say, that is what is covered underneath Medicare. That is very limited amount of time that Medicare will provide that physical therapy in a home. When you think about how home care basically is structured for a minute, I want you to realize that the primary care insurance, whether there's Humana, whether there's TRICARE, anything connected to the primary insurance and or Medicare piece, Medicare was never designed for the purpose of ongoing care in somebody's house. Okay, Medicare was always just designed for the purpose of short-term rehabilitative assistance. So when people need to have ongoing personal care or companion care, that is always a private pay scenario, unless somebody had a long-term care policy, or you had also then applied for Medicaid, which again, I can continue to elaborate on that too, if you ever wanted to reach out to me on that part. We do accept Medicaid as a form of payment when somebody is approved for that. And hospice is the highest level of care that somebody can have. We offer it, and so as we go through a continuum of care, that is that last piece that that provides that comfort and support for somebody. So as I go into 2 weeks from now, becomes a whole other part of this conversation that talks about the stages. I do elaborate a lot on hospice and the benefits and the usefulness of hospice and what that whole thing even means. So so if I can be of any assistance to you, Scott, or whoever else is on the call for additional home care understanding of how that is pieced together, and hours, days, costs, and all that stuff, please feel free to reach out to me directly. My direct phone number is 757-406-42. Oh, there you go, 4236. Okay. Anybody have any questions? Any other questions?
Hi, can you hear me now?
Yes. Hi, Shireen.
Hi, hey, hello from New Zealand.
Wow.
It's 10 o'clock a.m., so that's a good time. Just wondering if you would be releasing your slides or the recordings that you've got so that we could just hear it again and again if we needed it.
What the library is doing actually is putting it on their Facebook page. So you'll be able to listen to that and just click on there. Right, Martha?
Yes, and Joan, is it okay if we send her your entire slideshow? I know you didn't get through everything today.
Yes. Sure. Shireen, if please know, and Scott and whoever else, I'm going to be doing the second part to this presentation in 2 weeks. So on the 18th, we're doing it at 11:30 in the morning, and on the 21st, I'm doing it at 5:30. So in that presentation, I'm really going to go into some really great depth about how these stages really move and groove over time, and what we really should be picking up on to help identify where our loved one is in these stages so that we can continue to plan and strategize correctly.
Sure. Thank you. Thank you for that.
Sure. Scott, did I answer your questions okay before?
He says yes. All right, great. So We are at time now, so thank you all so much for attending. We will get the recording of this presentation put up. If you would like the entire slideshow, for people who are watching right now and who might not be live, go ahead and shoot me an email at Josette, Josette, .dubois, D as in dog, U, B as in boy, OIS, at norfolk.gov. And keep an eye out on Eventbrite for more from our dementia series and other great online programming that we're doing.
Thank you. Have a good night.
Good night, everyone.
Bye-bye.